So I'm going to extend what I discussed in the first talk again with G12R and pancreatic cancer. So now we're going to focus this talk on what the atypical mutant tells us about pancreatic cancer therapeutic strategies. So again, you guys saw this slide a little bit earlier, and I want to highlight again the biochemical defects of G12R are unique relative to other RAS mutations. So, most RAS mutations are gap insensitive, and this is what promotes their GTP loaded levels. G12R is unique because it also doesn't interact with its GEF, SOS1, so that actually makes it resistant to the SOS inhibitors as well. And that was recently published, I think also by Boehringer, but also in my papers as well. And then it's also gap insensitive, and then because its intrinsic biochemical properties of GTP exchange and hydrolysis, it's locked in its GTP state. So G12R and G12D share a lot of differences biochemically, but again, both of them promote pancreatic cancer. I showed this earlier just to show that the defect of the structural differences manifests itself mostly, at least so far what we've found, in the inability to activate PI3K. So how does G12R overcome this defect? We know the activation of PI3K pathway is a necessary step for RAS mutant cancers. And there's actually about 3 different mechanisms. I'm going to highlight all of them very briefly that allow, or at least we think, the G12R to overcome this in pancreatic cancer. One of which is PTEN oxidation. So PTEN is a cysteine phosphatase. It's a lipid phosphatase, and it's known to turn off PI3K signaling by hydrolyzing PIP3. It's effectively the brakes to this pathway. This oxidation turns off the catalytic function, and you can detect this via a non-reducing Western blot via these 2 bands here, and this has been previously published in other cancers, but not reported in pancreatic cancer. We think that the preponderance of PTEN oxidation in pancreatic cancer is one step that allows G12R to drive tumors in pancreatic cancer. Another step that we think also promotes it is the overexpression of all 4 class 1 PI3K isoforms. So in most epithelial cells, PI3K alpha and beta are considered to be ubiquitously expressed, where delta and gamma are thought to be mostly in myeloid or immune cells. However, we can detect all 4 isoforms shown here in a panel of G12D and G12R PDAC cell lines in all of our cell lines, independent of the RAS mutation, again suggesting that PI3K pathway activation may be independent of RAS. We'll take that a step further and say that because G12R is unique, sorry, this slide might be out of order from where I wanted it, the G12R pathway itself, or patients have been used to come up with therapies that actually are effective for these patients. And so if you look at just G12R patients, you can treat them with cobimetinib, which is a MEK inhibitor, and gemcitabine, again, going back to what Scott talked about earlier, where you're combining targeted therapies and chemotherapeutics. And these patients do respond and have longer overall survival. However, this is the only instance of this in all of RAS-treated cancers where we've used a RAS mutation to use a targeted therapy that didn't directly target RAS. We've actually seen this as well in some of our collaborations, and this takes me to another mechanism that we think G12R uses to overcome its inability to activate PI3K. And so what we did here was we took a G12D cell line and used CRISPR to make it a G12R cell line. One of the big defects that you see is the inability of the G12R mutant to drive activated H and NRAS, shown here by these RBD pull-downs. There we go. Because of that, that means there's less total active RAS, all 3 isoforms, and that makes them more sensitive to the trametinib inhibitor, or a MEK inhibitor, again, supporting the observation by Bach-Ardalan at Miami. Oh, wrong button, sorry. And then because of that inability to activate all 3 PI3K isoforms, mouse tumors, where we do a xenograft model, the G12R version is unable to drive those tumors. Going back to the pancreatic cells, then we think that the mechanism that allows G12R to overcome this inability is the overexpression of KRAS. And so shown here, we have the G12D cells and the G12R cells, and we're just probing for KRAS expression. And you can easily see that G12R tend to have a higher overall RAS protein expression level. So again, that defect is overcome by then elevated expression of the G12R mutant. Next. And then despite all of this, the trouble that we keep running into, and I've talked about earlier, is that the G12R mouse is resistant to driving tumors. And so this is work we've done in collaboration with Chris Counter, who's also here today, And we've made G12R mutant mouse models, and these mice with the 12R allele are as healthy as can be, and they just never pass away from disease. So we're still not exactly sure why the mouse model is failing in this context, and despite the model being very useful in a lot of issues or a lot of specific instances, one place that I feel like the mouse model continually fails is our inability to translate therapies from the mouse to the patient. And I think that figuring out how to get the G12R mouse to develop tumors will allow us to develop a better mouse model to make that transplant or that connection. And so again, I want to go back to the RevMed inhibitor finally here to wrap up. And of course, the RevMed has the first GTP selective inhibitor, and it works very, very well. What we've shown here is it's an immunoblot using the RevMed inhibitor. It shuts down the MAPK signaling remarkably well. It's less effective on the PI3K signaling pathway, but it still does impact it to a degree. I've told you that the G12R structure is very different. So how does it actually inhibit G12R? So what I've done is I'm going to go back to structure biology. This is my roots. But for those of you who are unaccustomed to looking at these, I'm sorry. But effectively, you can see here, the green structure up here at the top is CYPA or cyclophilin. And this is the RMC inhibitor. And then the green structure on the bottom is G12D bound to CYPA. The blue structure is G12D by itself. And you can see they look identical. And so what is unique then with the G12R is that you can see that switch 2 region that I showed earlier is all perturbed, but when it's bound to cyclophilin with the RMC inhibitor, that switch region, this helix, comes back, and it actually overlays perfectly with G12D. And I think that what RevMed stumbled on here was this inhibitor binds through switch 1. It actually boots out the arginine from the active site and allows switch 2 to reform that helix and then forms the exact same structural complex. So it's a really fascinating interaction for how this inhibitor works. Just running out of time, I'm going to jump through here, but this was shown earlier. Resistance still arises despite these inhibitors being very remarkable when used in second line. And one of the reasons that we think that can occur is because the PI3K pathway is still being activated independent of RAS in these contexts. And this is just one example where you can see the RevMed inhibitor used. In this case, we're using the tool compound, and it fails to shut down the PI3K pathway in the presence of IGFR. So there's ways for the PI3K pathway, at least, to be activated independent of RAS, despite the inhibitor still working very, very well blocking RAS. So I think that combination therapies are going to be necessary to inhibit all of these pathways because RAS doesn't always do everything we think it does. So with that, it's just a highlight again, GTP inhibitors are going to inhibit lots of the RAS mutations, whereas the GDP will inhibit only a select few at a time. So I'm going to just jump through and say thank you and move on.